Thank you, Mary, and Mike, thank you for accepting the introduction from, it was Steve Mayfield, actually, who is a professor here as well, who had been reading some of the stuff on my blog and suggested that part of what I write about might be suitable for a discussion like this. So, before the talk, Mary had requested I give at least some explanation of why I find this topic compelling, because it's actually quite circular. I am a physician, but I don't practice medicine in a traditional or clinical sense anymore. In fact, as soon as I completed my residency, I left. So I did my residency in general surgery at Johns Hopkins and my fellowship in surgical oncology, and then just had a real change of heart and decided I didn't want to practice clinical medicine. So I joined the consulting firm McKinsey & Company and actually wanted to get as far away from healthcare as possible. So while at McKinsey, I worked in credit risk modeling and banking services. Nevertheless, I've meandered my way over to what I'm doing now, which, as Rachel, one of my colleagues, has alluded to, is starting a nonprofit organization called the Nutrition Science Initiative, which we, at least in the eyes of the IRS, started in January, and more formally and publicly will probably be launching in the next 4 weeks. And I've co-founded this organization with a gentleman that some of you may know, Gary Taubes, who's a science journalist, and for whom actually much of the content in this presentation really comes from a lot of the research Gary did between the period of about 2000 and 2005. On a personal level, as evidenced by the fact that my trainer is here, I'm a sort of person who's always been physically active and always sort of valued exercise and whatnot. But interestingly, sometime around my 30th birthday, things sort of started to change in my life personally, and I just turned into a really sort of chubby person, which was quite frustrating to me because I was sort of doing everything I was told. I mean, I think it's one thing to say, gosh, I'm 50 pounds overweight and I'm eating M&Ms and sitting on the couch all day. It was another thing for me to be, doing very long swims and bike rides and eating my skinless, boneless chickens and, not eating eggs and doing all the right stuff and yet becoming on the cusp of obese and certainly having what is going to be known as, some of you know, metabolic syndrome, which is a cluster of 5 symptoms which really are the central theme of the diseases that we see related to obesity. And so through my own work and personal experimentation largely, I came to appreciate that, that the dietary recommendations as they were formally laid out did not apply to me. In fact, the exact opposite applied to me. That led me to the discovery of the work of Gary and others, and ultimately a friendship with Gary, and I came to realize that I may not be unique. In fact, it may be that as much as 60 or 70% of the American population also doesn't seem to respond too favorably to the formal recommendations set forth, which made me ask broader questions, and that kind of leads to the talk today. So, if it's all right with folks, I'd like to try to get through the talk and then go to a Q&A after. We've got plenty of time, and I'm more than happy to spend as much time as folks have. The reason I say that is not that I am not used to being interrupted. I have a 4-year-old daughter, so I'm very used to being interrupted. But the talk is actually, it's as you can tell, it's a history lesson. We're going to cover 60 years, but I don't do it in a perfectly linear fashion. I'm going to jump around a little bit. It's the only way I can tell the story. So with your patience, please allow me to do that, and I promise we can come back to addressing everything. So in the words of one of my surgical mentors who, when doing long operations, used to always remind me, Peter, it's fast on the straightaway, slow on the curves. So we're going to do that today. There's going to be some parts of this which I'm going to whip through really quickly, and there's going to be other parts when I slow the car down and I really want to point out a tree on the side of the road. So if you wonder where the tempo is coming from, that's it. So I alluded to this at the beginning. I have personally an enormous interest in this problem, not just as someone who was formerly overweight, but more importantly, I think, now that I've come to realize the social and economic toll of obesity and its related diseases. And I sort of liken the United States to a cruise liner that's trying to navigate its way around icebergs. And every one of us probably has an interest and a deep knowledge about what some of those icebergs might be. In other words, these are the things that are really going to get in the way of the cruise liner. So it could be, energy security, it could be pension overhang, it could be educational mishaps. But I personally believe, and I believe there's more than sufficient data to suggest this, that the closest iceberg to us is actually healthcare, is the cost of healthcare. And it's related to this. So let's just go over some of the things that I think most people are probably aware of. In the United States, the rate of obesity has really skyrocketed in the past 40 years. So since the time I was born, we've gone from a prevalence of obesity of 15% to about 35%. Perhaps more disturbing than that is not just the rate of growth of type 2 diabetes, which is very closely linked to obesity, but more importantly what the derivative looks like. In other words, on the obesity curve, we're actually seeing a somewhat flattening of the curve. Some people find solace in that, but no one is disputing that the derivative on the diabetes problem is not just growing, but it's increasing exponentially. And so why is this happening? Well, you know, if you'd asked me this question 5 years ago, I would have said it's happening because Americans are fat and lazy, right? Even though I was sort of one of them. I wasn't lazy, but I was certainly overweight. And you know, one of the things that was most humbling to me when I first read one of Gary's books, and it all sort of came together that this wasn't just about me anymore, this was kind of a more global issue, was this realization that back, you know, when I was clinically practicing medicine, how often subconsciously I sort of judged people who were diabetic and overweight. And it wasn't a judgment that I don't think ever came through in the way I interacted with them, but it certainly existed in the back of my mind, which was, if you would just stop eating so much, you know, you wouldn't be here having to let me amputate your leg. If you would just stop eating so much, I wouldn't have to do X and I wouldn't have to do Y, and you wouldn't have to cost the healthcare system Z. But let's take a look at that. So if you look at the NHANES database, it shows the consumptive pattern of Americans going back for 40 years. And you'll notice that carbohydrate intake has increased steadily over that period of time, while fat intake has declined commensurately, and protein intake has remained largely flat. If you look at another database, the FAO database, so this is the Food and Agricultural Organization, they give you an even more granular breakdown of what happened over that same period of time, which is that grain consumption specifically increased by 39%. The consumption of butter and eggs fell by about 38%, and the consumption of all animal products fell by 13%. So we can certainly take comfort in knowing something, which is when the American people were told to do something, they actually did it. Now, what I'm not showing you here is that overall caloric intake has increased, and I have no doubt that we will have a discussion about that over time. But the caloric increase in and of itself does not actually explain what we're seeing. Now, you'll notice that in parallel to the change in macronutrient composition, we also witnessed a stunning rise in the level of obesity. And these are the same data that I showed you a second ago, except they're broken down by subcategories. So now you can actually see that virtually every demographic of the population has seen this increase in obesity. And what I'm not showing you here, but is perhaps most disturbing, especially folks in the room who have an interest in childhood health, is that the incidence of diabetes type 2 and obesity in the child population is increasing at an alarming and stunning rate. Finally, I wouldn't be a true McKinsey former consultant if I didn't show you something about the economics of it all. This analysis was carried out by Ed Levine at McKinsey in a large healthcare report that was published in January. This looked at the growth of economic, the GDP growth and compared that to healthcare spending. You know, the United States spends more on healthcare than any country on earth in absolute dollars, per capita dollars, and percentage of GDP. So we spend 18% of our GDP, $2.4 trillion on healthcare. That's about $8,000 per year per person. And I've heard a lot of people rationalize that by saying, well, we're entitled to it. We're the most prosperous country in the world. It's okay. I would argue that would be true if this weren't true. If we were able to match economic growth to healthcare spending, it might be true. Now, I'm saying nothing about the quality of the healthcare we're providing or the disparity of it, but just put that aside for a moment. This is where I come back to my argument about sustainability. That gap is getting wider. It's not staying the same, it's not getting narrower, it's getting wider. So healthcare spending, as you can see, has outstripped economic growth since 1960 by 5x. It's not clear to me how much longer that's sustainable. I've heard others suggest we've got about 15 years to resolve this. Okay, so what we're going to do today is talk about one very specific issue. Now, there are a lot of issues we could be talking about today because tragically the story I'm about to tell you is true for many of the recommendations that people are given. And I contemplated doing this talk at a very high level and going through all of them. And in the end, I decided about a week ago, I'd rather tell a deeper story and allow you to understand that by extension, the story I'm going to tell you about fat, saturated fat, and cholesterol is actually true in salt. It's true in a lot of other things as well. So what are the recommendations? Okay, Intakes of dietary fatty acids and cholesterol are major detriments of cardiovascular disease and type 2 diabetes, two major causes of morbidity and mortality in Americans. By the way, about 61 to 62% of Americans every year die of these diseases and their related diseases. In order to reduce the population's burden from cardiovascular disease and type 2 diabetes and their risks, the preponderance of evidence indicate the beneficial health effects that are associated with several changes in consumption of dietary fats and cholesterol. These include limiting saturated fatty acid intake to less than 7% of total calories. So that's what we're told to do. That's what we've been told to do for 40 years, and actually we're doing a pretty good job. American consumption of saturated fat is probably just under 10%, so we're not quite there. Okay, well, let's take a look at the evidence. So the Food Agriculture Organization, the World Health Organization expert consultation paper in 2009 said the available evidence from cohort and randomized controlled trials is unsatisfactory and unreliable to make judgment about the substantiate the effects of dietary fat on the risk of coronary heart disease. Furthermore, there is no shortage of studies, and we're going to go through many of them, but I use this one as an example because it's one of the more recent ones, one of the larger ones, and it's got certainly some of the most prestigious authors on it, that commented in 2010, a meta-analysis of prospective epidemiologic studies showed that there is no significant evidence for concluding that dietary saturated fat is associated with an increased risk of coronary heart disease and cardiovascular disease. Okay, now begins the history lesson. So let's go back to 1951. A couple of really interesting things occurred at this time, really two things. One is President Eisenhower had a heart attack around this time. Now that was interesting because it was a rather public discussion about it. So he didn't have his heart attack in public, but after the president had his heart attack, it became a very publicly open and interesting discussion. And if anyone's read about this, and there was actually an article in the Financial Post about this 2 weeks ago, which some of you may have seen, it went through the whole story in a very elegant fashion. The remainder of Eisenhower's life was a consistent removal of fat from his diet. The poor man, at the time of his death, was eating only Melba toast. So that's one event that occurred. The other event that occurred, completely unrelated to that, but you're going to see there's a recurring theme here, which is serendipity, or lack thereof, confluence of events. The other thing that occurred in the immediate post-World War II time period was the development of a technique to measure something in the blood called cholesterol. So you've all heard of cholesterol, and unfortunately, though it's probably one of the top 3 things I'm interested in life, I won't, for the sake of time, be able to go into that today. But nevertheless, cholesterol is a molecule in the body that is essential for life. In fact, there are rare genetic disorders where people can't make or absorb cholesterol, and these disorders are fatal in utero, essentially. But nevertheless, we finally figured out a way to actually take all of the particles in the blood, and there are really 5 main particles that carry cholesterol in the blood, but there's a technique that could break them all apart and just count the total amount of cholesterol. Okay. Ancel Keys is a name that may ring a bell to some of you. He was a physiologist and nutritionist at the University of Minnesota. He and his wife, Margaret, visited Italy in the early 1950s and took with them this new technique for measuring cholesterol. And they did just that. They measured cholesterol and fat content of the diet and compared that with 2 different populations. So a group of wealthy people who were eating a higher fat diet and had higher blood levels of cholesterol, and a group of workers in the field who were commensurately not doing that. So these people were consuming less fat, and they actually had lower risk of heart disease and cholesterol. So a year later, Keys presented his hypothesis at the World Health Organization meeting in Amsterdam by saying that fatty diet raised serum cholesterol, atherosclerosis, myocardial infarction. So eat fat, raise cholesterol, get heart attack. That was the thesis. Within a decade, and I'm going to give you a little bit more detail in the middle, within a decade the American Heart Association had effectively adopted this. And they said in a 4-page ad hoc report from an ad hoc committee that included Ancel Keys' conclusion, the best scientific evidence of the time strongly suggests that Americans would reduce their risk of heart disease by reducing the fat in their diets and replacing saturated fats, specifically with polyunsaturated fats. In 1957, Ancel Keys published something called the 5-country study. The 7-country study wouldn't be published for another 13 years. this was a study that became really the blueprint and the staple for nutritional studies. It's observational epidemiology. So these aren't experiments. They're not controlled. You don't manipulate anything, but you follow people either prospectively or, in the case of Ancel Keys, retrospectively, where you look back at data. The 5-country study took countries that had a known disparity in their consumption of saturated fat. So at the top of the curve, you had the United States, Canada, and the UK. At the bottom of the curve, you had Italy, Japan, and France. And I can't remember exactly which countries made it into the 5-country and not the 7, etc. But the point is there was a very clear correlation. It was a straight line. The countries down here, Japan, Italy at the time, that were consuming scant saturated fat had a very low incidence of heart disease. The United States, the UK, that were consuming fat up the wazoo, dropping dead of heart attacks all day long. And by 1961, Ancel Keys was on the cover of Time magazine saying that the ideal heart-healthy diet should be 70% carbohydrate and 15% fat. Okay, so the competing philosophies. Let's talk about what the proponents have to say about this. We're going to come back to the McGovern report in a little while. That's the sort of informal name. But nevertheless, this commission that was run through the Senate between 1968 and 1977, the conclusion of this was a report that was published. And this report made formal the dietary recommendations that we're going to talk about. And I'll get to that in a second. But the point here is the dogma of the day was we don't have the luxury of time to find out the truth before making policy. So to tie this into the theme of ethics, it's an important question because sometimes you don't have the time to find out the truth, perhaps, and you have to make your best judgments. But that is formally the position of the United States government in 1977. Of course, the opponents and skeptics would argue the opposite. Without definitive evidence, we don't know if we're right. And I would add by extension, we don't know if we're doing more harm than good. Okay, so let's take a walk down selection bias lane. So in 1957, again, this was the year that the 5-country study was published, Ancel Keys noted that each new research adds detail, reduces areas of uncertainty, and, so far, provides further reason to believe. But is that really true? I'm going to talk at length about the Framingham study later on and put it in the context of the 5 cohorts that were examined. But Framingham is far and away the most famous of them, and to this day we continue to learn things from the Framingham cohort. But the positive data showed that in the Framingham cohort there was a link between cholesterol and heart disease. A link is another way of saying an association or a correlation. The people living in Framingham, Massachusetts who were who had higher levels of blood cholesterol were having more heart disease. The negative data, of course, were that in women over 50, cholesterol had no predictive value of heart disease. Now, there was a lot of unpublished data between the 1950s and the 1980s, and delayed publications on data and things like that. But one of the more interesting pieces of unpublished negative data from Framingham was, again, this is a cohort comparison that took several thousand patients, but compared 2 polar tranches of them. So they took the group of patients in the Framingham cohort who had serum cholesterol levels above 300 milligrams per deciliter. That's a very high number. From a percentile population, that would be in the top 5 percentile. They compared those men to those who had under 170 milligrams per deciliter. When they did that, they noticed that there was actually no difference in the amount of fat that they consumed. So it was interesting to note that they couldn't find an association, and typically this is a trick you do to call out differences, right? I mean, if you take the most stark examples, you can see these differences, but they couldn't even find an association, a correlation between what these men were eating and what was going on. There is considerable range of serum cholesterol within the Framingham study group. Something explains this inter-individual variation, but it's certainly not diet. And at the time, they didn't know what it was. More negative evidence when you look through multiple populations, so the Benedictine Trappist monks, Navajo Indians, Irish immigrants to Boston, the Swiss alpine farmers, the Maasai, the Inuit, other Africans, there was no association between the consumption of saturated fat to heart disease. Well, Ancel Keys rejected these as having no relevance to diet, cholesterol, coronary heart disease relationship in other populations. In other words, for reasons I don't entirely understand, these populations weren't relevant, but the other 5 populations were. Okay, let's revisit selection bias with a bit of a double click. In 1957, Oglesby Paul and his colleagues conducted an observation without an intervention. So they went to the Western Electric Company and they selected 5,400 men. I believe their ages were sort of 30 to 50-ish. And they didn't conduct any intervention. They just followed them. They just observed them. They didn't ask anybody to do anything except record what they were eating. And at 4 years, they published their results. The results were revisited 15 years later. They compared the 15% of men who reported eating the most amount of fat and contrasted them with the 15% of men who reported eating the least amount of fat. So it's sort of a similar trick to what we saw in Framingham. Let's take the extremes and ask what's happening. Worthy of comment is that when they followed these men over 4 years, of the 88 cases of coronary artery disease that occurred during that period of time, 14 took place in the group eating the highest amount of fat, 16 took place in the group eating the lowest amount of fat. In other words, there was actually no difference. Several years later, Jeremiah Stamler and colleagues returned to Western Electric and compared heart disease mortality and morbidity to fat content in the diet from 1957. So now they had a much longer period to follow up. And they concluded that the amount of saturated fatty acid in the diet was not significantly associated with the risk of death from coronary heart disease. In other words, they reiterated what was shown at 4 years. And so one of the criticisms of some of these studies has been you're never looking at a long enough period of time. So one of the big fallback positions has always been, well, you didn't notice a difference at 3 years or 4 years, but if we did this for 50 years, we'd notice a difference. Maybe so. But nevertheless, 15 years later, there was still no difference.